Hey guys, welcome back to another podcast. I believe this is 135. This is part one of maybe a 2 or 3 part series of just some loose dialogues Ivo and I have had, which we recorded in podcast format, of course, which is why it's here, but on running and center of pressure and center of mass. And you know, if you've been with us for a while and you've been on our social media pages, you've seen some debates we've been having with some folks about head over foot posturing and where the center of mass should actually be. Should it actually be over the foot, meaning center of pressure, over the middle of the foot, or should it be within the width of the step, meaning step width? And we argued that it should be within the step width somewhere, meaning center of pressure might be, if you had stood with 2 feet down, the center of pressure of both feet would be the equivalent of your yard, and there's a fence demarcating the center of pressure of each foot, and your center of mass should be somewhere within your yard. It can be right up to the fence, but it shouldn't be standing on the fence, because the risks mount as you stand on the fence. You can fall over into the other yard, meaning you can drift over into where your center of body mass is outside your foot line, which means now you've got a supinate, you're into a pelvic drift, you've got a crossover gait, all of these issues. So we always like to say that it should be within the center of the step width, or within the step width, excuse me, not in the center, but within the step width. And the more narrow your gait, the narrower your yard, which means probably, as if you look at some high-level marathoners, they become very narrow in their step width, which means they're very economical, but their liabilities increase. And so you've got to keep in mind that you can play with these narrower step widths for economical reasons, but your liabilities may increase, and you need to have enough durability on your system to sustain those liabilities and maximize your economy within those limits. So this is just part one. This is Ivo starts off on some neuro stuff, and we go a little deep here, but for a good reason, because people need to understand the neurology behind how the body finds this center of mass and center of pressure and correlates the two to find balance in the upright position in the gravitational plane. And if you don't understand that, then you're not having a full dialogue. And so we're going to start with that, and then we're going to go into some talk and dialogue on our thoughts on this, and we followed up with a future podcast down the road. It'll be the next one, actually, on the same topic, and we pull out some research and try to make our case. And admittedly, there's been no research out there that makes our case or makes their case, but at least we get close with some research, we believe, that seems to make our case fairly relevant. And I guess that's what matters, but it's what opens up a debate. But what happened was, as I looked back on this in months gone by, these guys were always talking about the clock, and it's just about what makes someone faster. And our approach wasn't about the clock and speed. It was about treating people with problems and making people safe and economical and durable. And I think that's where a lot of the debate and arguments came up, was because our perspectives and our outcomes were different. Ours were about getting people safe and economical and healthy and in good, clean biomechanics, and the other folks just thought about speed and didn't care about anything other than the clock. And to each his own. People come to you for different reasons, and you've got to meet those goals. And we don't like to play on the liability side, and that's not what people come to us for. They don't come to us to get fast initially. They come to us to get healthy and to clean up problems, and then to get fast. So keep that in mind as you hear these dialogues and as you go back and read some of those debates. Debates are always good. Made us really sit down and look at our perspectives and our opinions, and really evaluate them and see if we really had a reason to believe what we have believed. And I think we are unwavering at this point. We're certainly happy to open up our thoughts as research comes out, and but nothing as of yet. So we're going to stand our ground at this point and try to work off of the research that we do have that suggests that we're probably right. And the initial part of this dialogue today on this podcast will be Ivo talking about the neurology side of it, and we base all of our stuff off of what we do know, which is neurology and how the nervous system works, and then we move from there. So we hope you enjoy this dialogue. If you find this one good and useful, and you think some friends might get some value from it, your coaches, trainers, other doctors, therapists, as always, send them the link, forward it on. So enough talk, let's get on with it. Here we go. All right, we're back. I'm here with my good buddy, Dr. Ivo. How are you, pal?
Doing great, thanks.
Yeah, good. Good holidays?
Holidays were great. How about you? You went to Canada,
complaints.
didn't you?
Yeah, I made a quick trip up to Canada to see my parents, yep. But quick trip, was back later that week in the office, as I know you were as well, seeing people. So, but everything's good. Back in the clinic, good to be back in the clinic, and good to be back with another podcast. You guys are going to hear that dialogue and think it's just after the Christmas holidays and New Year's, but this is going to probably be at the end of January, early February, but we'll see. We may actually bump this one up, and if you're hearing it sooner, then you know we bumped it up. But hey, I came up with a study here. This one this was out of the Guardian, but there was another study on, we've talked about this before, about nursing mothers and as a whole, and mammals prefer to cradle babies on the left side, study demonstrates. We've talked about this, but they've had some new research revealing that humans, like other mammal mothers and babies, prefer to keep each other on the left side in that left visual field. And, it's just, walking around with a kid on your left side, most people are going to dump that pelvis over into that left frontal plane to try to, help provide a little bit of an arch or a shelf, if you will, for the baby to kind of rest on the mom's hip. And it certainly gets the mass of the baby over top of the foot a little bit more, makes it a little less fatiguing, but we know that doing that chronically is going to load the QL on that side and put some challenges into the spine with lateral flexion and some aberrant coactivation patterns, and who knows, some breathing alternate patterns because of the rib cage on that side. So just another study to show that doing something repeatedly or for long periods of time has a consequence, as with most things in this world. But I know you hadn't sent that or seen this one. I just sent it over to you just before we hit start here. But you have any comments on that other than the obvious?
I do. And one of the things, we run into this because we don't see a ton, but we see a fair number of concussion patients. And, we do different treatment modalities and stuff with them. And when you place something, and you said this right off the bat, placing them in your left visual field. When you place anything in your left visual field, you stimulate the nasal side of the left retina and the temporal side of the right retina. And those fibers, through pathways that we won't necessarily go into at the moment, are basically going to feed into the right side of the brain. So even though the input is somewhat bilateral, it's going to be predominantly on the right side. Mm-hmm. Cortical pathways, some cortical pathways, particularly the autonomics, but other stuff as well, are going to be hemispherical. In other words, certain things are going to occur on certain sides of the cortex. And our intermediolateral cell columns, our sympathetic nervous system, our autonomics, are largely driven unilaterally by the cortex. So if I put input into I'll give you an example. If I put input into my right visual field, okay, the right side of the brain drives what we call chronotropy, or how fast the heart beats, whereas the left side controls inotropy, where that's basically how hard the heart beats. And if you remember, a number of years ago, there were all those kids right when Nintendo came out that were dying of heart attacks, all these young people and stuff. And that was because of the cortical mismatch which occurs. Because visual field stimulation is a very, very strong and powerful form of stimulation. So you kind of have to wonder, knowing that certain sides of the brain, are analytical, certain sides are creative, that kind of stuff, by putting that kid in the left visual field, if that's going to affect those pathways on one side more so than the other.
Yeah, and just to be clear, because we've bounced from left to right, left visual field, but right cortical field, right?
Correct. So everything if I'm looking out straight, everything to my left is my left visual field, and that'll strike the nasal half of my retina on my left eye and the temporal half on the right eye.
Right.
And that information comes back, right?
Yeah.
Yeah.
I want people
optic
to realize
nerves, optic chiasm, optic tract.
Yeah. It's a little bit more complicated than stuff coming in the left eye goes only in the left eye. So,
it doesn't work that way. They both go to each side, whereas the information from the nasal half of my left eye crosses over to the right side, whereas the temporal on the right side stays on the same side. And then that information, is going to travel back through ultimately the thalamus, the lateral geniculate body, and then that goes back and takes believe it or not, 180-degree twist, so it's upside down when it projects into your occipital lobe in that area there, and that's where that information is stored. But those pathways, through association pathways, pass forward, and that's one of the things that's going to drive the autonomics. Rob Hugdahl did a ton of work on this back, believe it or not, in the 90s. He had a great book called Brain Asymmetry that came out. I think it was Lippincott Publishers, which was just absolutely fascinating. And then you can do the same thing kind of with hearing. The guy named Joseph Halij did a lot of research with dichotic listening and stimulating, putting a stimulus in one ear as opposed to the other ear for a certain kind of effect. So you have to wonder what other sorts of cortical functions by doing that. Is it because people are right-handed? And if the kid's theoretically in your left visual field, you can use your right hand to do more stuff and it's a dexterity issue? Or is it actually more of a cortical issue? Whereas, it's just going to that right brain as opposed to left brain.
Mm-hmm. Well, and I put another one in here from CRISPR, but I think it's actually just more suited that we go right into that vestibular thing that you sent over earlier. Why don't you just take over the mic here for a little bit and school us all on some vestibular stuff and some new research that came up, because, standing upright in the gravitational plane is all about those three systems, and no one talks about it better than you. And if you're standing in that gravitational plane, we also know that we walk and we run in that gravitational plane. If you don't understand that a lot of these pathways, and I'm sure you're going to go into depth with this, it's a top-down process neurologically, but it's a bottom-up process biomechanically. But a lot of people think that there's a biomechanical process from the top down. Not saying you can't drive it there, but that's not how it works. It's not where it originates from. And so, but a lot of people think that they can make those changes by facilitating arm swing and crossing the midline of the body, or, changing position of the torso or center of mass or head and whatnot. So why don't you take the floor over here and talk about those three systems, and then talk about this article, because I think this is going to be very interesting. Hopefully you folks will too, but make sure you take them down a path that they can understand if they don't have a big neurologic brain like you.
Well, I'll do my best. Whenever I talk about vestibular stuff, I always think back to before I moved to Colorado, I was asked by the Colorado Chiropractic Association to come out and give a seminar. So I gave them a bunch of topics, and then one of them was all about dizziness and vertigo. So if you can imagine, I put together an entire weekend just on the neurology of dizziness and vertigo for this group of chiropractors out in Grand Junction. It was fairly hilarious. We went through a lot of stuff, a lot of great information, went through a lot of rehab things, but that was began a lot of my interest in the area. But anyway, I was searching for an article on something else, which is usually how I run across stuff. And I stumbled across this article earlier today. It's out of the Journal of Electromyography and Kinesiology, which probably doesn't sound too exciting to some people. But basically, gait has a lot to do with muscles and how they move. So this is one of those journals there. The article's called, and it came out in 2017, February. I'm sorry, 2018, it's going to come out. So it's actually before publication here. It's called Mechanisms of Head Stability During Gait Initiation in Young and Older Women, a Neuromechanical Analysis. And neuromechanics is just a cool field. Robert Enoka talks about it quite a bit in his book, Neuromechanics of the Musculoskeletal System, and there's a bunch of different, issues of that. But basically how the nervous system and the musculoskeletal system interact. So what they did in this particular study is they looked at head stability, in younger women and older women. So in other words, it's been reported that in older women, head stability is decreased during locomotor transitions, such as the initiation of gait. In other words, when you have to initiate gait, we think about that sudden forward movement. We get extension of the head. We're going to engage the SCMs. We're going to engage the posterior musculature. We're going to hopefully engage our core. We're going to come up and do that. And in this study, the gist of it is older women had a higher variability of head angular acceleration and displacement, a decreased ability to attenuate, accelerations from trunk to head in anterior posterior but not lateral positions. In other words, they couldn't attenuate as well going from flexion to extension, but laterally it didn't really make much of a difference. And then they had delayed onset of muscle activation, particularly the sternocleidomastoid, than in younger people. So that really doesn't sound too earth-shaking, but it does bring about a bunch of things that we like to talk about, particularly when it comes to gait, balance, foot placement, step width, things like that. And that is, there's three systems that keep us upright in the gravitational plane. We have the visual system, we've got the vestibular system, and we've got the propriosensory system. Of course, the vision system, or visual system, that's pretty obvious. The vestibular system consists of the utricle, the saccule, and the semicircular canals. They're found inside the petrous portion of your temporal bone, so kind of in your ear region, or your inner ear, you can think of it, in our skull. And in there, the semicircular canals, these three hula hoop-like structures, are filled with this viscous fluid called endolymph, which, if you imagine three hula hoops at 90 degrees to one another in the three different cardinal planes, as you move your head in one direction, the fluid in the hula hoop moves in the opposite direction, and then that stimulates your nervous system and tells us that we've had angular motion. And then there's these two other structures inside that detect linear acceleration called the utricle and the saccule. And we can get into all the physics of what's going on, but suffice it to say, the vestibular system is largely for the position of the head, and the head only, as far as the vestibular apparatus. And then finally we have the propriosensory system, which consists of the joint mechanoreceptors and muscle mechanoreceptors, things like spindles, Golgi tendon organs, and things like that. We can exemplify this, and we've talked about this on the pod before, but we'll review it here. If you're listening and you're not driving, you're just listening, what we want you to do is stand up. Okay, so stand up, stand on one leg, it doesn't matter which one, unlock your knee just so it's slightly flexed, and then can you stand there stable for 30 seconds without falling down? And if so, good, that means your three systems are working well. So then what we do is we have you close your eyes. So we're taking out the visual system, and now we're being a slave to the other two systems. And can you stand there with your eyes closed, knees slightly bent, for 30 seconds without falling down? And if you're trying to make it a little more challenging, lift your toes up and leave the ball of your foot on the ground like your foot tripod. Finally, what we can do, so that takes out the visual system. And if you start to waver, then you know you have a problem with your vestibular system as well as your propriosensory system, and you should make steps to try to fix those. Different vestibular exercises, balance coordination exercises and activities, things like rock climbing, riding a bike, skateboarding, etc. So finally, since you're standing there with your eyes closed and you're able to well balance, now I want you to open your eyes. I want you to extend your head and look up at the ceiling. So your head's extended about 60 degrees. Okay. Then what I want you to do, see if you can balance there, and if you can, then I want you to close your eyes. Now, our semicircular canals, the lateral semicircular canal, is at about a 30-degree angle to the horizontal, and when I put my head upright into a position looking at the ceiling, raising it about 60 degrees, it basically means that the canal now is vertical, so it pretty much takes that canal out of the action. And the other canals, because their orientation, aren't going to be nearly as affected. So if you have your eyes closed and you can stand stable, and now you extend your head and you close your eyes and you're not stable, now we know that your joint mechanoreceptor system isn't working so well because we've taken the vestibular system out of the picture at that point. And then we need to make treatments or therapy or whatever directed at, we think as chiropractors and a lot of people as PTs, physiatrists, osteopaths, improving joint motion, improving muscular integrity about joints and things like that. So modalities like manipulation, mobilization, therapeutic exercise, all of those things are going to come into play. So we've got the three systems that keep us upright, and that's a real simple test you can do to kind of test and do each system. So with that being said, understand that as we age, there's an age-related degeneration that's going to occur of all three systems. Vision, we get cataracts, our, vitreous fluid becomes less viscous, where lenses are less pliable, muscles don't work nearly as well. We become oftentimes somewhat myopic at first, and then somewhat hyperopic, and then your arms just aren't long enough to read the paper and things like that. So we have this age-related degeneration of that, as well as retinal neurons We have an age-related degeneration of mechanoreceptors, both joint mechanoreceptors, which atrophy, as well as muscle receptors. And we'll have an age-related degeneration which occurs of the vestibular system. And I think going back to the study, what we're largely seeing is partly this age-related degeneration. Now, the younger gals in this particular study were, and it's a small study, like 22, 23 people. The younger gals were, basically 22 to 24 years old, and the older gals were basically from about 70 to 75. And, it's not surprising that muscle activation and things like that are just not as good when you age because of all of these factors that are going to affect that. So again, nothing earth-shaking, but it really makes us think about what's driving, in enabling us to balance. So with all of that being said, just to throw a few more things into the fire here before we kind of stir it up and talk about it a little bit, when we look at balance and coordination information, it's going to come from those three systems and come in. The upper four cervical levels, so like C1 through 4 at cord levels, feed directly into the flocculonodular lobe of the cerebellum. We remember from our posts and things like that the cerebellum is intimately involved with balance, coordination, as well as learning. So they feed directly in. So you have to understand most information that's going to travel to the cerebellum is filtered first through the brainstem or through the thalamus. But in the case of the upper four cervical vertebrae, they go directly in. Now, also think about what is the innervation of the sternocleidomastoid, right? It's the spinal accessory nerve and C1, C2. So, okay, so this might be a real important postural muscle along with that other branchial arch muscle up there that attaches to our neck called the trapezius. And that's probably why those two things are often impaired after people have whiplash accidents and things like that, because those particular parts of the nervous system are damaged. So this information feeds into the cerebellum, okay, the flocculonodular lobe, which is kind of the bottom part. It looks sort of like a little add-on. And then the important part about that particular lobe, because the cerebellum has 3 lobes, the important part about that lobe is that projects directly to the vestibular system. So it comes out, it goes to the brainstem, okay, in the floor of the fourth ventricle, and it's going to go to the superior, inferior, medial, and lateral vestibular nuclei. So we've got 4 vestibular nuclei. 3 of those nuclei move your eyes, and 1 of those nuclei goes back down to your spine and fires all of your axial extensors. So it makes us stand upright in the gravitational plane. So I'm sure if we were to measure eye movements with an histogram or something like that with these individuals, we probably would have seen some impairment in that as well. And I think some of these perturbations, particularly in the A to P plane, like we're talking about sagittal plane, front-back movement, is going to be affected by what's going on because your vestibular system largely drives the musculature, axial core muscles, on the anterior and posterior aspects of your body, predominantly posterior because it drives your axial extensors and allows us to be upright and go forward and backwards. So when we start to see impairment of that system, the whole thing starts to break down and gait becomes more primitive, like we've talked about so many times. You slow down, you become more wide-based in your gait, which is more stable for that particular position, as well as you're going to have increased arm movements in an attempt to create balance. So if we were to take one of these individuals now, they're going to try to center their weight somewhat more, or center their mass over whatever point is on the ground at that point, so probably their foot. So you're going to see increased amounts of sway and movement, largely because they need to be more, you could think of it as centered as far as that goes. So getting back to what I was talking about at first, a lot of what we have to do with step width and things like that, and of course there's a lot of other factors, but one of the major factors that's going to drive that is those 3 systems, the proprioceptor system, the vestibular system, as well as the visual system. And if you look at the literature, and I've done this recently because I've been looking at some other things for both gait guys as well as some of the courses that I teach in dry needling and things like that. But a lot of that foot placement information is driven by vision as well as vestibular system. Now, you can say, oh, well, look at blind people, right? They can walk, and it's pretty normal. But look at blind people and look at their gait. And it is somewhat different compared to a lot of other people's gait that have sight, because they're relying on the 2 systems, not the 3 systems. Plus, they're dragging in the auditory system, because those senses are going to be somewhat more enhanced to facilitate them being able to maintain balance and not fall down. So I guess in summary, the 3 systems really are what's going to drive where we're going to be, or where your foot's going to be, where your body placement's going to be, and to some extent, I imagine, where your speed is going to be, and some of your agility. The better the system works, so in other words, the more we train it specifically, the better off people are generally going to be, coordinated and move, less prone to injury, faster, that kind of stuff. And there's ways that we can augment the system with contracting certain muscle groups or holding a certain body posture or things like that, that can make a profound difference in our performance. Now, we've seen this, and you and I have talked about this, it's been quite a while, but we talked about that, I think it's Under Armour, but it might have been somebody else, the mouth guard, and how with people have increased strength when they're biting down and utilizing their TMJ, because we're feeding into the trigeminal nucleus and the trigeminal cervical complex up in that area, but we're basically feeding that neuronal pool, getting things to work better. Anyway, I know that you probably want to talk about a lot of other things, so I'm going to be quiet now and give you the floor.
I just woke up from a little neuro nap here. No, it's people have been with us for the 130 some odd podcasts here. Have probably heard that 2 or 3 times, and there's a reason for it, because you need to hear it 2 or 3 or 4 or 5 times to get it, because it's a complex system. The system is always looking for stability. You said something right at the end there that I think is really important. We can do a little demo for those folks who can stand up right now and stand on one leg. If you've got a impairment of one of those 3 systems, you're going to seek stability in other ways, and you're going to maximize the systems, the 2 that are maybe working better than the one that might have a deficit, whether it's vestibular or cervicogenic, spine mediated, or if it's going to be visual. So, an athlete is going to be able to find stability in a myriad of other positions. So do this, everybody. Stand up and stand on your right foot. And we've talked about the crossover gait a lot. So stand up and stand on your right foot and find some good posture, get into your glute, and make sure that your left knee is in a little bit of hip flexion and a little bit of knee flexion, but that it's moving straight forward. So let me give you another example. Put both feet down on the ground. Imagine that there's a balance beam or a 2x4 between your feet. Stand up on your right foot, but make sure that your left leg is still progressing forward along the line of that 2x4. In other words, I don't want your left knee crossing the midline of your body. You'll notice that when the left knee crosses the midline of your body, meaning the hip is abducted or adducted across the midline, you feel more stable over your foot. You'll also notice that the pelvis on the right side might actually drift out a little bit more over that foot, causing the foot to supinate a little bit more. So you've brought your center of mass directly over top of your right foot that you're standing on, and you've helped that happen by bringing your left knee across that midline. Now, if you were to put that left foot now on the ground, you'd be doing a crossover gait. You might actually cross right over. Instead of walking on a line, you might actually cross over the line if you were moving forward, which is not normal walking. It's maybe drunk walking, but so an athlete, that's not going to make a good athlete, but a good athlete's going to be one who can stabilize over that foot and move that leg in multiple positions. They can move it over to the left across the line. They can make a pivot and turn. But someone who has a deficit, whether it's posturally or sensory-wise in the foot or ankle because of a sprain or because of a vestibular problem or a visual problem, they're going to try and find stability. So they're going to try and pack all that center of mass over top of that foot. They're not going to want all these extraneous parts floating out into other planes where you have to have more stability to control it, which is what makes an athlete good. You have to be able to do all of these things, make cuts and stuff like that on the field, if you will, if you're into a lateral sport. So do you have any comment on that before I continue on? Because that's really trying to get your center of mass over your center of pressure. Center of pressure is where your foot feels most stable. So any comments on that?
No, but again,
thoughts?
like I was saying before, basically, I should say no, and then I go to talk, right? So yeah, I guess I have a small comment.
Yeah.
I mean, it's driven. It's brain driven. It's driven by your vestibular system, which is determining angular and circular, angular as well as linear acceleration of your head, as well as your propriosensory system and your visual system. So yeah, I agree with all of that, and we're going to try to seek that stable center.
Yep. Yeah. And so, there's that whole dialogue that we've always had about step width, about where the center of mass should be within the confines of that step width. And we've always argued with some backing on that, but there's no definitive research. However, I will mention that I just received moments ago an article from my brother, who's at Harvard, the coordinated movement of the spine and pelvis during running. And they do talk about some things here, which is quite interesting about center of mass being within the... I just read it while you were going off on your detailed stuff there. I can't find it here. We'll look for it again. They talked about the antiphasic gait and the foot posturing and where the body mass should be, at least in theory, during locomotion. And it's difficult to... Gait is... I mean, you and I have said this many times. Gait is highly complex. I mean, listen to the first 20 minutes of this podcast, you'll understand, oh my God, this is completely neurologic mediated. And then you've got to figure out how to biomechanically get those parts to do what the brain just said, assuming that all the parts are working. They don't have any deficits. You don't have, a neuropathy and you can't feel your feet. You don't have a chronically sprained ankle. You don't have an ACL that's not yours, or a knee replacement that's was bought and paid for. So there's a lot of these issues that go into it, plus the asymmetries, which goes back to our very first topic today, where you're carrying a child or on one side, or you're throwing a spear, or you're carrying a water bottle when you're running, or a briefcase when you're walking. I mean, the gait has to have all these adaptive things, so you can't simplify this as much as a lot of folks want to try and simplify it. God, I wish we could, because it would certainly make our jobs a lot easier, wouldn't it? One of the things I do in my office, and jump in any time because I'm just kind of going off on a tangent here. I did this with a runner this morning, and about to get on a FaceTime with a runner down in Australia who has this, that same pattern that I just talked about, where they're standing on the leg and the knee crosses the midline, because a lot of runners do that, and that's a searching for stability. And I've got permission for this gal to put the video up, and what she's doing is she's translating her body mass all the way over her foot, but she's having all these chronic problems, and her times are getting slower and slower as her gait has degraded into this crossover gait with a lot of medial knee positioning, and trying to keep her center of mass and step width really narrow. So I have a lot of my clients, I put a Pilates block right between their feet, about the 6-inch width. And I just, in a standing position, and I just say, I want you to slowly lift one foot and try to find your balance point. And they put the foot down, and then I'll have them do that to the other side, stand on the other leg. And inevitably, a lot of these folks who have an asymmetry, and a lot of people come to my office have pain. They're not there just for biomechanical optimization, but some do. But a lot of them have a problem, and a lot of them don't have a lateral line of stability. They've got weak glute, weak core on that side. Weak hip stability and weak spine stability on a side. And on that side where they have that instability, as they transition the opposite foot off the ground to stand on that side, they feel like I have to, a lot of times they'll just say, I had to shift a lot further into that frontal plane to find a sense of stability, to find my balance point. And then we have them step back over onto the other foot, and like, I didn't have to shift that far. I said, I know you didn't have to shift that far because you didn't have to bring your mass all the way up over your foot. Okay, maybe they did, but it didn't have to bring it over the center of the foot. They could get over the big toe and the medial tripod a little bit. This is not gait. This is just a standing body weight shift. But when there's a deficit in that frontal plane, we've talked about the frontal plane pelvis drift and all of that. They have to shift a lot further to find a sense of stability because they don't have enough strength like they do on the other side to find it early enough. So they have to shift even further to find their stability point. And then we go through some things like marching bridges and some of the progressions that I do with that helps them realize, oh my gosh, when I have to have stability and even in a non-gravitational plane, I mean laying supine in the gravitational plane, they notice that the hip stability isn't there either. So that's just one of the little tricks that I do. But and then I show them, I take the Pilates block out and I put their feet together, and they don't feel that shift anymore because they don't have to shift, because the body mass is already over a small centralized spot. So the greater your step width is, the more stability you have to have. And if you don't have that stability, every time you take a step, you're going to want to shift your body mass up and over that foot, which is a lot of zigzagging of your body mass in the frontal plane, or at least a diagonal frontal plane, back and forth. That's not efficient gait. There is a slight wavering. It's a slow, small sine wave of the center of mass going left to right as you're walking, but it shouldn't be this huge translation of your whole body mass right over the foot each time. That's not effective propulsion. That's very ineffective, and if that was the case, you'd see a lot of these long distance runners with a lot of body mass shifting. Now, caveat, a lot of them have a very narrow step width because it's more mechanical, but we've said this before, a narrow step width is more efficient, but it has greater risks. So your liabilities are increasing, but your economy is also increasing. So you've got to play the risks and the rewards there. But like a sprinter out of the blocks, they're going to be very wide with their step width, but they can be very wide because they're trying to create a massive amount of force in the forward plane. But in order to do that, you've got to keep your body mass on the inside and drive off the leg. Kind of, I always say, think of a hockey player. They're driving off, but you don't see them putting the body mass up and over the skate. The body mass stays in the middle, and they're driving back to the midline each time, and that's what propulses them forward. Before the podcast, I said, just stand on one leg and get your body mass over your foot and try and drive medially. So stand on your right leg, get your body mass over your foot and try and drive medially without shifting your body mass. You can't. You have to have the center of mass inside the foot a little bit in order to drive off towards that side, to drive back medially to the midline. So it kind of proves that you've got to keep your body mass within that center of mass, but we're trying to find some literature to the problem is there's just not a lot out there, but it's very interesting that people who have the stability can have a wider step width and not have gait pathologies. But if you don't have that lateral stability in the hips and in the core, you're going to have a narrower gait, which is why we see a lot of runners who have a narrow base gait or a crossover gait and have a lot of problems in the hips. They've got a lot of chronic IT band problems. They're going to be pronating the foot a little bit further. So kind of a little bit of a tangent there, but you've got to have the system that you said prior to all of that intact. You've got to have a vestibular, you've got to have the proprioceptive, you've got to have the visual. So I'm giving you the mic here. I need to catch my breath. I get excited about this stuff.
I think everything that you're talking about is very valid.
Yeah.
As far as that goes, I mean, it is what it is. This is just the way the system works, and the way the way that gait and locomotion works to a large extent. So.
Yeah, I'm looking for that little piece of information there. So, when someone has like a chronically sprained ankle, we've talked about the pronae and how much of a problem that is. If you were to step off of your left foot onto your right foot, and you've got a proprioceptive deficit in that right leg that you're stepping onto, you're going to try to minimize risks of further inversion and obviously try to still maintain an upright gait and stability of the joints. If the body mass transitions too far up and over that foot and goes, I always call that the fence, standing up on top of your center of pressure over your foot. Center of mass over center of pressure is the fence. You're sitting on the fence. On the inside of the fence, your center of mass is inside that fence. You can push right up against the fence, but you're still inside, meaning your center of mass is still within the confines of your step width. The moment your center of mass steps off that fence too far laterally, you're into a lateral pelvic drift. And in order to save yourself, quite frequently, you'll tip the foot out into supination, which puts you at risk for another ankle sprain, which is why this happens a lot of the time when there's not an event or a foot you're stepping down on or a pothole you're stepping into. a lot of these folks, if you're stepping your body mass up and over that foot, you're progressing your center of mass diagonally forward, which means your center of mass is going up and out over the lateral foot and you're supinating. That means the next subsequent step, you're not going to be able to get over your big toe and over the medial foot tripod to push off again. So now you're stuck with a bit of a propulsive problem or an apropulsive gait, or you're going to have to change that foot in the frontal plane, which we see a lot. You're going to see them spin the foot out and be more duck-footed, if you will, to try and find that medial tripod. Plus, it gives them more stability in the frontal plane by turning the foot out, because now the quadriceps and the knee are more in that frontal plane, and you can utilize a quadriceps strategy instead of a glute strategy. Obviously, you see this in your office a lot. How do you approach those types of things? Do you immediately go into some stability work with the foot, or do you do some gait retraining? How do you approach those types of things, and go on any tangents that you care to with that?
We look at, a lot of different factors. I pretty much look from the foot up most of the time, but I'm also kind of keeping a keen eye on what's going on nervous system wise. Like you were saying, if your if your foot positioning dictates that you need to move your center of mass, that's fine. But if you start to lean too far, let's say to the right side, your head is going to tilt to the left. Okay, and the reason that's going to happen is because of your vestibular system and your visual system kind of having a mismatch. We've got a muscle called the superior and inferior oblique, which basically control how far the eyes can rotate to the right, not like laterally move, but rotate within the socket from side to side. And we can only tilt our head so far, and then the world starts to tilt. And when the world starts to tilt, the brain says, no, I want my visual axes parallel, please. So as a result of that, you're going to start to move the body more in compensation to that, which of course is going to change where your center of mass is going to fall. We see this in people, particularly hockey players, that get whacked in the orbit. Okay, with a puck or a mountain biker that hits in that area. A lot of times what happens is they damage either the superior oblique muscle, or more often or not the trochlea, or the little pulley that the muscle runs through in the aspect of the orbit. So what that does is that changes the amount of in or extorsion that's going to occur in the eye. And you're going to get this head tilt or possibly neck pain or whatever, because that eye is not moving appropriately within the socket. In other words, if you're looking straight ahead, and you had a toilet paper tube over your right eye, and you twisted that to the right and the left, that's the motion I'm talking about. So it's ocular rotation in addition to lateral plane movements and things like that. So we try to pay attention to what's going on with that in addition to anything else. I have a tendency to really lead with footwork and proprial work. Proprioception is one of my big things in the office, only because I've had a lot of personal experience with myself, with proprioceptive exercises and endurance-based exercises really helping much more than strength-based exercises and things like that. Mm-hmm. And then rather than retraining movement patterns, a lot of times what we do is we look, well, how are they moving and how is that efficient? And if that's not providing a satisfactory result, how can we make that more efficient or a better movement for that particular client? Understanding that for some people, the crossover gait might be how they got to run. Because they got a big tibial varum, they got a big supinatory foot, they got a big cavus arch, they got genuvarum, they got internal tibial torsion, they got femoral retrotorsion, and they just have to run that way because that's the way they're wired. And we're not going to try to force them into something else, although we may try to make them more efficient, and we may do that by trying to improve the range of motion in those joints. We may do that by placing a wedge in their shoe. We may use a foot leveling orthotic. Again, it's really going to depend. And it really is, sure, there's generic stuff that we give out, but it needs to be pretty tailored. Because the reason, and I'm sure it's this way in your office, the reason a lot of people come to see you is because they've already been everywhere else. They've already done all the basic stuff. And the basic stuff that works on 80 to 85% of the population didn't work for them. So they need something different, specific, whatever that is. And it really can vary. Because I'm a foot nerd, I generally start, from the bottom and work my way up. But I've always got an eye towards what's going on from a proprioceptive, but as well as, eye movement standpoint and things like that, just because you can make such a huge difference in how somebody's functioning just by changing the way that they have things coming into their visual field. And, you're going to get cues to a lot of that just from doing a full physical exam. People are like, you're a chiropractor. What are you looking at my eyes for? Why are you listening to my heart?
Yeah.
What are you taking a pulse oximetry for? Why do I need to do blood work? Because we're trying to be comprehensive and get to the bottom of what's going on. And we don't fix everybody.
Yeah.
We help a lot of people, but I like to tell people, it's like, look, I don't fix you. I just help you to compensate better. That's my job.
Yeah. Well, and to be fair to the process, because a lot of people listening aren't in the field of medicine, but they're in the field of training and coaching and stuff like that and performance. And, a lot of those folks, they're just trying to make their client stronger, faster, and so they're more performance based. And I get that, but that's not what people come to us for. They don't come to us and say, hey, I have all this hip pain, but really all I care about is being faster. They're coming because they got a hip problem that's causing them not to be able to become faster. So we're we're almost, a step down further towards the roots of the tree instead of at the ground level. And so, our approach has to be a little bit more biomechanically and neurologically sound. And so our approach in our writing is going to be a little bit different from that perspective too. So we're going to be a little bit more nitpicking when it comes to the details. Whereas a lot of folks are going to a trainer or somebody or a coach or a speed coach or on a team, the goal at that point is to try and just become faster and become a better athlete. So you kind of have to understand that there's two roads and they're both moving forward, but they're clearly different traffic on those roads. There's different information on those roads. There's different needs and different wants and different demands on those roads. So to be fair, that you can't take our information and try and say that our information is going to make someone faster. We never guarantee that, but we're going to probably say you're a little bit more biomechanically sound, that maybe when you go back to your trainer, you might be able to withstand some of the loads of the training without getting injured, which may then allow you to be faster. And on that topic, we look at things a little bit more in detail. For example, the antiphasic nature of gait. What is antiphasic nature? Well, the antiphasic nature of gait is what allows the left hand to go forward when you're walking with the left foot to go forward. So as the left hand moves forward in the sagittal plane, the right foot goes forward in that plane. So there's this counter rotation of the shoulder girdle with the pelvic girdle. That's called antiphasic gait. We know, and Stu McGill has proven, that when someone has spine pain, that antiphasic nature becomes more phasic, meaning there's less differential between the pelvis rotating obliquely and the shoulders. They tend to start rotating in the same plane or at the same time, which obviously leads to a very shorter step length and step or stride length. And it's gonna obviously narrow step width a little bit too, because you're going to start to try and find a center of mass that's less torsionally loading the spinal motor units or the spinal segments. And so because we know that when we wring out the spine with that antiphasic gait, there's more compression through the core because there's more torsion. There's more coiling, which is what makes athletes more efficient. But when someone's in pain, McGill's studies showed that actually reduces. And so when you're in a walking or a running gait, you have this normal antiphasic nature. And the antiphasic nature of that, which creates this coiling, reduces the need to create frontal plane movements. Because the coiling nature of arm swing and leg swing is what makes it most efficient without having to engage that frontal plane, which is where there's power leaks and deficits and obviously pathologic gait patterns. And so when someone loses that antiphasic nature, they tend to move more into those frontal planes. They tend to move the center of mass further towards up and over the foot quite often, and sometimes beyond it, which creates that frontal plane drift. And that's what drives it. So when you see those patterns, the antiphasic nature has been shifted as well. And that's why in those folks, quite often, if you just watch them walk, one arm isn't swinging as much as the other. And you'll notice that if you're really, really careful, that they're making some pelvic distortion rotations to try and normalize the step lengths, because the step lengths have to be the same length for them to move in a straight line without compensation. We use the visual cue to do that. If you give a person a big enough field and you put a blindfold on them and they've got an asymmetry, they'll walk in a circle. But if you take the blindfold off and you show them a target on the other side of the field, regardless of their asymmetry, they're going to find a straight line towards the target, but they're going to do that by changing the antiphasic nature and changing some pelvic distortion patterns and some hip rotation probably. And you're going to find some compensations to drive a straight line, even though the mechanical system is saying, we're not working the same on both sides here, guys, but the goal is driven by the visual system. So when you take all of those things into consideration, which is a beautiful place to end this perhaps, is with you talking about the vestibular system, keeping the horizon stable, looking at the visual system, keeping the trajectory stable on the horizon with binocular vision and parallax view and all those things that we've talked about many a time. And then the proprioceptive system, in a perfect world, there shouldn't have to be any adaptations, but we know that there is. And this is why when you see someone walking a straight line with some of these compensations, one arm doesn't swing as much. The leg lengths or the step lengths are actually equal, but that's because they've distorted the pelvis a little bit, or they're moving into the frontal plane, or they're making some other cheats in order to actually try and get the legs to actually work the same step length to try and get the target there. But maybe we need to dive into the literature and look for, well, maybe the power output on one leg is different, and that's what changes the step length. It gets really complicated in a real hurry. So, I don't know. I know I went off on a tangent there, but you can't negate the fact of that antiphasic nature and how the arms and the legs communicate with each other, both centrally mediated and locally mediated through spinal reflexes and whatnot, and through some of these primitive motor patterns that collage and DNS and a lot of those things go into. So it's a really highly complex system. Do you want to throw anything in there at the end there to kind of tie all that together? Do you have any thoughts or comments?
Not necessarily something's going to tie it together, but something else to think about. Like, arm swing, we like to think should be symmetrical, but it's not. And sometimes it's not because of cortical issues that are going on. You look at people that have strokes and things like that, that becomes really obvious. But then you have more subtle cortical dysfunctions that are going to occur that are going to alter, arm swing and gait patterns. And, there's so many different neurological reflexes and stuff that are going to be affected by the things that we all do with our patients on a daily basis. So, not neglecting the function of the brain that's driving the whole bus here. When you see a change, you may just do one small thing. And then after you do that one small thing, and maybe that was joint manipulation, or give them an exercise, or you had them do a certain pattern, or you gave them some water, or whatever it was, can change the entire system and how that system functions. Because, all of the things that we do to a patient, in addition to footwear they're wearing, all that stuff, is going to have a profound impact on how that's all going to integrate. So sort of like epigenetics, are going to control so your environment, your surroundings, that kind of stuff are going to control the expression of certain genes. What we do to individuals is going to determine how the nervous system, the vestibular system, the visual system, the proprioceptive system, all of that, how it's all going to react to what we do. So, sometimes, people have a cortical lesion that's going on, but it's not like, they have multiple sclerosis or Lou Gehrig's or something like that. It's something much more subtle, and it's more of a physiologic kind of lesion rather than an actual mechanical, physical boo-boo that we can see on an MRI or something like that. And, Dr. Carrick used to talk about physiological lesions all the time in his lectures. And, conceptually, it's very plausible. Do I have theory that I can show you that's not theory, but a paper where I can point to and say, well, this is the way that it is? No, but with the amount of stuff that's out there, the effects that you have are going to affect what's going on. Just like ground surface can make a difference in gait. Shoes can make a difference in gait. There's so many other factors that are involved. And I think just looking at all of those things together, which is what makes us all kind of holistic practitioners. We're just looking at, you got plantar fasciitis, so we need to take the stress off that plantar fascia. It's like, well, why did you develop in the first place? Did you really injure your plantar fascia and tear your plantar plate? Or was it that you don't have enough hip extension, or you don't have enough ankle dorsiflexion, or, and the list goes on and on and on.
Yeah.
Well, I am really glad we had this talk.
I think there's probably more to this, but for now, I think we're done. Well, it's a rabbit hole, isn't it? It really is. It
really is. And, the more I read, the more I realize that I don't know. I'm just like, holy smokes, I didn't know this, and then I go down another whole rabbit hole of information and stuff. It's never ending, and that's the great thing about it. And then, bringing it all back together and putting it, how it's going to affect how we move and our gait is just like one of my favorite things to do. So
yeah, me too. And now that my brother has fed us even more articles over from our Harvard feed, we've got a whole bunch of new human movement science journal articles and a couple more, so we got more reading to do, man.
Yeah, let's pop those guys in, and then let's maybe talk about those next time.
Yeah, we'll see if we can do that. Thanks, pal. Anyways, thanks for joining us. We know you guys are busy, but we always appreciate your time and always your feedback. We don't know everything. We don't pretend to, but we know a fair amount, and we like to share it with you guys. And there's always going to be some stuff that's new out there that we're going to try and bring it to you guys to make ourselves smarter, but also you guys as well, so the whole community can go to the next level. So if you come across something cool, send it our way. We'll have a look at it. We'll try to digest it, and maybe it'll correct us. Maybe it'll actually elevate us. Who knows? But that's the whole game. So anyways, Shawn Allen here in Chicago.
Ivo Whirlup in Colorado. We will see you. I'm not going to say the shoe aisle this time. We'll see you around.
Yeah. See you there.